Great. Thanks so much for that, Lee. Welcome, everyone. We've got nearly 140 of you joining us, and we are now recording. This is the 5th offering of Open Classroom, and we are delighted to have you here with us today. I'm looking forward to today's presentation. As many of you may be in these unique moments in our time, I have wanted to hear from an epidemiologist, and today that's exactly what we're going to get. I've never appreciated our public health scholars and practitioners more than I do right now. And among them is Kim Johnson, who's an associate professor at the Brown School. She has been teaching epidemiology foundations of public health for a decade. She is a cancer epidemiologist by specialty, and her research focus is on disparities in cancer survival. Please welcome my friend and colleague, fellow parent to a WashU undergrad, Kim Johnson.
Thank you. Janet, should I just go ahead and start then?
Let's
I'll
do
share
it.
my screen. Okay. Okay, as Janet mentioned, I'm an associate professor at WashU, and I have been teaching epidemiology for 10 years now. Seems like it was just yesterday when I started. So welcome to my classroom online, and here's the outline for the next 30 to 35 or so minutes. So in part 1, I'm going to tell you what is epidemiology. In part 2, we're going to talk about how epidemiologists measure disease in populations. In part 3, we're going to talk about how epidemiologists understand causes of disease in population. In part 4, how do we use this information from parts 2 and 3 to control disease in population? And then in part 5, we're going to focus specifically on COVID-19, frequently asked questions that Janet gave me, so I had to do some homework. And there'll be plenty of time for you to ask questions as well. So what is epidemiology? Well, when I was first introduced to epidemiology, I learned that epidemiologists take care of populations. So as this cartoon illustrates, I'm sorry, Dr. Etheridge is an epidemiologist, not a general practitioner, but maybe if you get a group together, he would see you. So doctors take care of patients, and I like to think of epidemiologists as helping to take care of populations. So epidemiology is situated within the broad field of public health, and public health is defined as the science of protecting and improving health of people and their communities. Epidemiology is one of several disciplines in public health, including social and behavioral sciences, biostatistics, environmental health science, and health services administration and policy. So here's the formal definition of epidemiology that we like to teach our students, because I think it captures everything that epidemiologists are involved with, and that is the study of the distribution and determinants of health-related states or events in specified populations and the application of this study to control health problems. So let's break this down a little bit. What epidemiologists do is they gather data to understand where disease is occurring. So we call this person, place, time data in populations. And that just looking at the data to see who it's occurring to, when it's occurring, what places, that is called descriptive epidemiology. So that's often the first thing that we do in order to understand health problems. And then the second thing is that we aim to understand why it is occurring in populations. So after we do the descriptive epidemiology, we can start to see patterns and ask questions and formulate hypotheses to determine why it is occurring in some populations more than another. And so we look for both modifiable risk factors and non-modifiable risk factors. So modifiable risk factors are things like physical activity, weight, whereas non-modifiable risk factors are things like genetics. And we break this down into analytic epidemiology. So it's rough when we're asking why, that is part of our analytic epidemiology studies. And then the third thing that we do is we try to use the information we learn from 1 and 2 to design interventions to present and control disease in populations. So we operate under a couple of core assumptions to guide our activities. One is that health outcomes are not randomly distributed in a population. And two, the causes of health outcomes are multifactorial. So many factorials come together to cause a person to be in better or worse health. So here's an example of one, that health outcomes are not randomly distributed in a population. This is data from the New York Times. They have these maps of COVID cases, and this is from April 3rd. And we can see that there's not a random distribution of cases around the United States of COVID-19. And if we didn't know anything about what was happening, we could speculate that something is different, some factors different in the environment on the East Coast versus the West Coast. But of course, we know that the distribution of cases has to do, is because of an infectious disease, and there's more population in certain areas than others. And also this variation has to do with testing as well. So number two, the causes of health outcomes are multifactorial. One way to think about this is probably one of the older ways of thinking about the multifactorial causes of health is what's referred to as the epidemiologic triangle. So you're going to find this in every intro to epi textbook. And this triangle works well for infectious diseases where you have a combination of factors that cause a person to have disease. So you have an agent, so an infectious agent like COVID-19, influenza, the virus that causes COVID-19, influenza or measles. These agents differ in terms of their pathogenicity, so how much severe disease they'll cause, or their infectivity, how likely they are to infect a person if they're exposed. Then there are host factors over here, and host factors that incur a person to have more or less susceptibility can be genetic factors, age, certain behaviors, whether they're vaccinated or not. And then there's also environmental factors, so factors that influence exposure and transmission, so housing density, social distancing policies. So all of these factors interact to make a person more or less susceptible to the development of an infectious disease. So how do we measure disease in populations? So we have to collect data somehow, and so we do that through surveillance systems is one example. So we have really great surveillance systems for cancer that are nationwide. I'm going to give an example of that in a minute. Also, there's special reporting for infectious diseases. I'll tell you a little bit more about the COVID-19 reporting. We also collect information to measure disease through surveys, and these can be nationwide surveys, or they can be just specific subgroups, people within a community, people within an organization. We also use administrative databases, so health insurance claims databases would be one example, and electronic health records. So there are many ways that many different sources of data for our activities to measure disease in populations. So I'm very familiar with cancer surveillance as a cancer epidemiologist, and we collect data on cancer diagnoses in virtually the entire US population. And this is done through the Center for Disease Control's National Program of Cancer Registries, and also through the National Cancer Institute's Surveillance, Epidemiology, and End Results Program. And data on cancer diagnoses are mandated by law, so you have to report them. They have to be reported in a population, and they're collected from a variety of sources to ensure completeness. So you can see some of these sources on the right. Hospitals are a major source, oncology practices, imaging centers. There's a variety of ways that we gather data on who's diagnosed with cancer. And most of our cancer registries have completeness of over 90 or 95% of cancer cases in the United States are captured. And so it's one of the best surveillance systems, I would say, in the world. And these data help us to understand trends in cancer over time. This is really important, both in cancer diagnoses and cancer survival. So if we have new treatments, are we going to see on a population level that someone with breast cancer, for example, a population of people with breast cancer, if the survival improves as a result of new treatment? The cancer surveillance provides data to identify high-risk groups for developing and dying from cancer. Cancer surveillance data helps with planning for cancer control programs in the population. It helps with deciding on resource allocation control, so what cancers are most common. So we're going to devote a lot of resources to trying to control those cancers. And it just generally, it advances our knowledge about the cancer burden in the US and globally. So moving on to COVID-19 reporting, the CDC has a standardized case report form, and this is shown here. This is taken from the CDC website. So health departments can, when they get a case that's been diagnosed, they can fill out this form electronically and submit it to CDC. And that helps us keep track in real time of the number of cases that are being diagnosed in the United States. So that's a little bit about how we collect data. So how do epidemiologists calculate disease frequency? So from these data. So we have several measures of disease frequency that we use, some of which you may have heard of. I'm giving some common ones here. Prevalence is the number of new and existing cases of disease in the population at any given time. So it doesn't matter when they were diagnosed with the disease. It's just, you can think of it as a snapshot of how many people are living with the disease right now in a population. So an example of that would be the percent of people in a population right now with diabetes. Cumulative incidence is different, and it is the number of cases, new cases of disease that develop in a population during a defined period. And this really helps us understand trends over time. So this is cumulative incidence is usually calculated on an annual basis. So for example, the number of new cases of cancer diagnosed per Missouri population in 2020. So we can use this data that we collect every year to compare how incidence is varying across years. Mortality rate is another measure, and this is like cumulative incidence, but it's the number of deaths in a population during a defined period. So the number of deaths per Missouri population in 2020. And then the one that you've probably heard a lot about lately, it's been on the news, been on your social media sites, people talking about case fatality rates. So that's the number of deaths among those who have the disease. So we're really interested in learning the case fatality rate for COVID-19. So this is the formula in actual, as I spoke it, number of deaths from disease divided by the number of diagnosed with disease. And that's usually expressed as a percentage. So accurate case fatality rates depend on accurate counts of death, the numerator, and diagnoses, the denominator. And I think this is really relevant right now because testing ability impacts the accuracy of both the denominator and the numerator for COVID-19. So when we have a shortage of testing, that denominator can be artificially small and make the case fatality rate look artificially high. So that's something to think about when you're just looking at number of deaths and divided by the number diagnosed in a particular area. This makes it particularly difficult to compare between geographic locations because of differences in testing for COVID-19 and differences which are related to differences in the ability to enumerate the number of individuals with disease and deaths due to the disease. So in the third part, we're going to talk about how we understand causes of disease in populations. So as I mentioned before, disease causation is multifactorial. Not everyone who smokes who gets lung cancer. Some people refuse to, or they don't quit smoking. It's really hard to quit smoking, and they may think that they're not at risk because grandfather or relative lived to be very old and smoked their whole life. But also not everyone who is infected with COVID-19 gets sick. So there's something about different between individuals that makes them more or less susceptible to disease, the same disease. I'm going to talk now about Rothman's causal pi model, which is another way of looking at causality. And this was inspired by, I was actually surprised in a Washington Post article where they talked about the Rothman's causal pi model as it relates to COVID-19. And I thought, wow, this is really obscure epidemiology piece of information that's now being reported in the Washington Post. So I thought I would go through it. So Rothman is probably one of the most famous epidemiologists of modern times that you've never heard of. And he's currently a professor at Boston University. He envisions disease as a pie where each piece of the pie, where each piece of the pie are causes of disease that must come together for disease to occur in a person. So shown here are 3 different people, 1, 2, and 3, and there are 3 different pies which led to them getting the disease. So the full pie for each person is, in Rothman's causal pi model, is a sufficient cause for the disease to occur. So this person, you can think about it as accumulating all these different causes through your life, and at the moment you get all the causes for a disease, that disease occurs. So each piece of the pie is a component cause. So A through P are all component causes for each person. And a component cause that is part of every person's sufficient cause is a necessary cause. So this works well for infectious diseases. A would be the necessary cause in this illustration, because we know that infectious diseases are caused by specific infectious agents. Like for HIV, you don't get acquired immunodeficiency syndrome without being infected with HIV. So HIV would be a necessary cause for acquired immunodeficiency syndrome. So let's look at this in the COVID-19 example, and this was inspired by that Washington Post article. So I'm giving 2 hypothetical exposures, male exposure and subway exposure, and as far as I've seen, there is no good evidence to indicate that you can get COVID-19 either of these ways. So please don't go home and sanitize. Well, you should sanitize your mail maybe, but don't overreact. So in the first pie model for male exposure, you can imagine a driver sneezes on the package and there is virus then on the package. You touch the same spot on the package and then you touch your eyes, mouth, or nose and you become infected with the COVID-19 virus. In the second subway exposure, in the second example, a person sneezes on a subway bar riding before you. So they both get COVID-19, but they have different causal pi models. There's virus on the bar. You touch the metal bar at a spot where the sneeze landed, and then you touch your eyes, mouth, or nose. So the necessary cause here is the virus present on both of these, either the package or the bar. So you can avoid being infected by not acquiring all these pieces of the puzzle, the pie puzzle. So the solution for both scenarios is to not acquire all the component causes that make up a sufficient cause. For example, don't touch your eyes, mouth, or nose after touching the mail or the subway bar. So that's kind of a framework for how we think about how disease develops. And so now I'd like to talk a little bit about study designs that are used to identify risk and protective factors for disease. So these can be broken down into 2 broad categories. 1, experimental studies where a researcher assigns an intervention. You may have heard of randomized controlled clinical trials. This is happening right now for hydroxychloroquine. And in this setting, and I think it's actually happening, I heard on the news this morning, it's actually happening this exact same way. participants are randomized to either treatment or placebo. And the second major category of study designs that we use to understand the causes of disease are called observational studies, where nature assigns intervention, meaning we as researchers don't do anything to, we don't tell people to change any of their behavior. We simply assess what their behavior is or what the exposure, what they've been exposed to in the past. And there's three major types of observational studies. One is a cohort study. I'm going to get into that as an example in a minute. Another is a case control study. And that's in a case control study, that's where we compare exposure histories or other kinds of exposures in cases, people with disease, to those without disease, to see if they're more frequent in people with disease. And then a cross-sectional study is where we assess both the exposure and the disease at the same time, usually on a survey. So let's talk about a cohort study for vaccination, how we might do that. So in this diagram, I have two groups of people. So I can assemble a group of people and I can divide them into exposed and unexposed. And in this case, our exposure is vaccinated or unvaccinated. I might learn if they were exposed or unexposed through a survey. I might just survey a group of people and ask them, were you vaccinated? So we're going to start this study today on 4/14/2020. And everybody, a key to a cohort study is everybody is disease-free. So they don't have the disease when you start the study of interest that you're following them for. So we follow the participants for a year forward in time to see if they get the disease. And then we get our results on 4/14/2021. We somehow measure whether they got the infectious disease over the course of that year. And we find that two of the group that was vaccinated developed the infectious disease. So that's shown as the red people. And so 2 of 10 equals 20% in the vaccinated group developed the disease. And then in the unvaccinated group, we find that 8 people out of the 10 that were unvaccinated developed the disease. And that's 80%. So we can already see that there seems to be much lower incidence of infectious disease in those who were vaccinated than those who were unvaccinated. So how do we calculate this? How do we calculate a measure for this? We calculate relative risk. This is probably one of the most popular measures of association. So relative risk is defined as the disease incidence in exposed divided by the disease incidence in the unexposed. So these are just what we ended with from the previous slide. So as I mentioned, the disease incidence in the vaccinated was 20%, and the disease incidence in the unvaccinated was 80%. So we calculate the relative risk as 20 over 80, and that gives us a value of 0.25. So how do we interpret that? The disease incidence in those who were vaccinated was 0.25 times the disease incidence in those who were not vaccinated, or it was 75% lower. And this provides us some evidence that vaccination prevented infectious disease in this group. So there are some considerations for interpreting epidemiologic data. One is the study design. So experimental results from randomized controlled trials are considered the gold standard. So these are the highest level of evidence that we have for cause and effect from human studies. Anecdotal case reports are useful for generating hypotheses, but are not evidence for cause and effect. Another consideration is study size. Results from larger studies are considered more accurate than smaller studies. Another consideration is how participants were sampled. Random sampling of the population is more accurate than other methods, such as studies that are solely based on volunteers. And the reason for this is because those who volunteer for health studies tend to be different in a systematic way from those who do not volunteer. And this can cause bias in our results. Another big factor, which I don't have time to get into today, is called confounding. It's one of the biggest factors we deal with in epidemiology studies. And this is where the study result may be due to another factor. So another factor that is correlated with our exposure and also is a risk factor for the outcome. So for example, I might find a lighter in a pocket is associated with an increased risk for lung cancer. Well, that is because cigarette smokers tend to carry lighters in their pockets at a higher frequency than non-smokers. So this result would be confounded by smoking. Okay, so after we've done our descriptive epidemiology and our analytic epidemiology, then we can use this information to design interventions to control disease in populations. So epidemiological data allows us to make informed decisions or evidence-based decisions about control measures. Through many, many years of research and that have led to a lot of evidence, we have made recommendations for breast cancer screening as an example. There are other screening programs, vaccinations for infectious disease, education and policies regarding smoking, and social distancing to flatten the curve is another one that I'll talk about a little bit more. First, I want to give an example of one of the biggest public health achievements is understanding the cause of lung cancer and conducting activities to reduce lung cancer in our society and other societies around the world. So I think this graph really shows, it's just descriptive data, but how our activities in public health have helped to reduce lung cancer. So in the early 1900s, we can see that per capita cigarette consumption went up all the way till about 1964, somewhere around there was a Surgeon General's report about the harms of smoking with regard to lung cancer. And we can see there's a delay, but we can see that now lung cancer rates are starting to drop. And this has been through much education around the harms of smoking, and people have started to give up smoking. And we also see for female lung cancer, we don't see it quite yet. We might, actually, it might be more recent data that shows it. And this pattern is because females took up smoking much later than males. So social distancing for the control of COVID-19 infection. This is a recommendation because we have lots of knowledge about how infectious disease spreads. And so it's led to this flatten the curve, almost a cliche now. That's what we're trying to do with our social distancing measures. And it's an effort to reduce person-to-person transmission rate. So social distancing and stay-at-home recommendations can reduce transmission rates. And this will help keep the health system from being overwhelmed, which will help save lives. So we have a lot of knowledge about epidemiologic curves. This is all theoretical, this chart, but that they have a shape somewhat like this if you don't do anything with infectious disease. So the thought is that if we didn't do anything, we didn't implement social distancing measures, our cases would rise quickly, and until we had a vaccination or we developed something called herd immunity where transmission is slowed because enough people have been infected, then we'd have a decrease. But the problem with this is that it would overwhelm the healthcare capacity. We couldn't deal with that many sick people at one time. And so flattening the curve is just spreading out this curve over a longer time period. So people aren't getting infected as quickly, and the healthcare system has the capacity to deal with that and can provide as much supportive care as it can to each patient. Okay, so this is the homework that Janet gave me. the frequently asked questions for COVID-19. So the first one is we're starting to hear rumblings of peaks approaching and declines in new case rates. Do you see hope in the newest numbers for St. Louis and New York City generally? So as an epidemiologist, I said, well, in order for me to answer this question, I have to go and I have to analyze the data. So that's what I did. I went to the St. Louis City Health Department's website and found data on number of cases and number of deaths by day, and also to the New York City Health Department's GitHub website, and was able to get that similar data for New York City. And this is what I found. So what I would expect to see, what we're expecting to see is that then if our measures are working, that the number of cases will start to come down, the number of hospitalizations will come down, and the number of deaths will come down. And so we can see from New York City data that these are just the number of cases in this panel where my arrow is, that we are seeing that the number of cases has come down recently. There's this strange pattern here that I noticed, and I realized actually this is weekends. So you have less testing being done and less diagnosis on weekends. So that's why you see that pattern. We also see a similar pattern, slightly shifted, for hospitalizations. We see that the number of hospitalizations in New York City for this disease has been decreasing. And we also see that the number of deaths has been decreasing. Now, one thing to be aware of is this number may go up. I mean, we shouldn't necessarily expect that it keeps going down over the next several days, because April 12th was Easter, so there might have been some delay in testing. But I think in general, there's a lot of hope that they are over the hump for New York City in terms of new cases. What's going to happen when we release these social distancing measures is another story. For St. Louis, the graphs do not look the same. So we're at a different stage of this local epidemic than New York City is. We're still increasing, the number of cases is still increasing. So we don't see any decline as of yet, and the same with the number of deaths. So hopefully we will be seeing some evidence soon that we're on the downswing for this. So comparisons, the second question was, comparisons have been drawn to influenza, especially 1918 and 1919, and also to HIV. What lessons do you think are apparent, and are the comparisons fair? So I think influenza is very different, especially the more recent influenzas. One, it has a shorter asymptomatic phase than COVID-19, and there's a higher percentage of asymptomatic cases walking around for COVID-19. Recently, I think the case fatality rates for recent influenza have been estimated to be a lot lower than COVID-19, so it's different. I would say it's more comparable what's going on now to 1918 and 1919. With respect to HIV, I think it's completely different, because HIV is a sexually transmitted disease. So by and large, so we have good measures for education for preventing HIV infection and different behaviors as well. And we also have treatment for HIV. So that's a little bit different there. But so I think the best comparison is probably to the influenza pandemic of 1918-1919, where you had a non-immune population, so everybody was susceptible, which is true with the new novel coronavirus. I wanted to show you some interesting data about what social distancing did in the 1918-1919 flu. These are curves for death rates in St. Louis and Philadelphia. So shown here, Philadelphia is in the dark black line, and St. Louis is the dotted line. So in Philadelphia, the first cases were reported on September 17th, 1918. And then they kind of ignored that. And then they had a citywide parade on September 28th, 1918. And then social distancing measures were not implemented till October 3rd. So we can see a very different shape of the death rate from influenza in 1918, 1919 than in St. Louis, where it looks like the curve was relatively flat. And there in St. Louis, what St. Louis did, the first cases were reported on 10/5/1918, and then they implemented social distancing measures such as school closings 2 days later, and so they had a very different course of the epidemic and a lower death rate. Another question is, African American populations appear to be experiencing mortality from COVID at a rate that greatly exceeds that of other groups. What do you think is going on? So as an epidemiologist, when I see differences between groups in either disease, development of disease, so a higher burden, one group is more likely to develop a disease, or one group is more than others, or one group is more likely to die from a disease than others, I started asking about what are the differences in risk factors between those groups that might explain this pattern. And for COVID-19, I think risk factors for development include housing density, living in multi-generational living situations, the type of employment. So some people are able to work from home while others are in jobs where they can't, the grocery, or they're involved with transportation. So I think that's part of the difference that we're seeing, at least for development of the disease. For mortality, I think I also asking those same sorts of questions, what's different? I think we know that certain comorbidities cause more or less, cause more disease or more severe disease, so such as hypertension, diabetes, and also access to care would be another issue I'd want to look into, because if you delay going to the hospital if you're sick, they might not be able to offer you as much supportive care as they would if you went earlier on in the course of the disease. So I think this plays into some of the patterns that we're seeing, unfortunately, for African Americans. I just wanted to give a plug for our public health program and the Brown School in general. Our public health program, it was ranked for the first time last year as a top 20 program, and it was especially unique because we're the only program in the top 20 that is not in a school of public health. So we're particularly proud of that. We have other programs, as some of you are graduates of it, that's great. So we have the Master of Public Health, and we also have social work and the Master of Social Policy as programs within the Brown School. And I think we all work really well together to help take care of the population's health. So I will take this time, that was Epi 101, so a very quick overview of our activities as epidemiologists. And I will take time now to answer any questions.
Kim, thank you so much for that. Many good questions, many very smart questions coming in, but I'm also leading it off. Just great gratitude for the talk and your time. So the first thing that I want to ask you is, are you okay to share these slides with the group? They're interested in receiving a digital copy, if that's okay with you.
Yes, I will send them to you.
Thank you so much.
Yeah.
Okay. And I think Lee and I are going to tag team. I'll start with something substantive and then throw it over to him. So we have Marcia and Maggie, both with questions really relating to the accuracy of data, availability of testing, sort of errors, and just kind of what do you make of, specifically related to COVID, about numbers of cases and numbers of deaths?
I think there's a lot of uncertainty in those numbers. I think number of cases is underestimated, maybe even by a magnitude or more, because of testing issues, and also because of there's many mild cases of disease or asymptomatic cases. So these people would never come to the attention of a healthcare provider to be tested. So yeah, I think there's a lot of underestimation of who has actually been infected with the virus that causes COVID-19.
Kim, we have lost your volume just in the middle of that answer. Something happened that made you drop off.
Can you hear me now?
Can hear you, but not as good as before.
Okay.
Yes.
it might be my distance from my computer. Yeah. So I think there's a lot of inaccuracy in the counts right now, both on the numerator end, the deaths, and the denominator end, the testing, like diagnosis. And that is because not all cases who have been infected ever come to the attention of the healthcare system to be tested because they're more mild or they're asymptomatic. And we also know, we've all heard that there are shortages of tests in different geographic locations throughout the United States and probably the world as well. I'm most familiar with US data.
Hey Kim, it seems like a lot of our attendees are questioning the resources. It seems like there's a lot of information out there, a lot of information overload. Is there a set of resources or a website that you use to really get the great, accurate information about COVID-19?
That's a really great question. I mean, there are a couple of resources that I go to often as just a consumer like everybody else, not as a epidemiologist. If I'm actually gonna look for solid data, my resources would be different. But I read the major papers in the United States. So New York Times, Washington Post, I have the CNN app, I scan Google News, I go to BBC. I'm like always looking at different sources for news, and especially if they're reporting on the same thing, to see if there is consistency in the way they're reporting in order for me to formulate my opinion about what is going on. For like more academic type questions that I really need the best data that there is, I go to health department websites, as I did for this presentation. I would go to the CDC. Johns Hopkins collects data. A lot of, I think, media outlets are using their data. Yeah, so that's how I approach it.
So we have several folks that are wondering about sort of impact of systems of oppression, structural racism in the current situation. And I understand that's not your primary area of study, but I am curious, they are curious for anything that you would want to share about sort of how those systems of oppression can relate to epidemiology.
So, yeah, I'm probably not the best person to speak of this, but again, as an epidemiologist, I would approach it. If I had a question about that, I would look to gather data to systematically analyze how that would be affecting disease. I'm sure it is. I'm probably not the best person to answer that. That's kind of out of the realm of what I study.
Kim, I have a two-part question for you. So after, the peak and as we're flattening the curve, how long should people continue to be socially distant? And then what are the risks that this may happen in the fall or in the future?
Okay, I'm speaking sort of as a person in the community who's also an epidemiologist. So I don't think anybody actually knows concrete answers to these questions. I think once we return to more normalcy, where we're not under, we're not in our houses and we're out and about, I think it's going to take a while. We're all going to be nervous until there's a vaccine or some sort of treatment. So I think social distancing in terms of distance from people will be present for a while. Just more care about how close you get to people, and washing your hands. That's always like our go-to thing with infectious disease, is to make sure that you're keeping your hands clean and keeping them out of your nose and your face, which are, for respiratory viruses, are the major portal of entry for infection. As far as, do I think it will return in the fall? That's, yes. I think to some level, but hopefully through testing and tracing and through people being more careful about their contacts and just hygiene, we can manage it.
So Naren is wondering about sort of the global situation, and sort of wondering, is your sense that we're likely to go through multiple cycles of this as international travel resumes, or to the extent that you have a crystal ball of what we might expect until there's a vaccine? How do you see the sort of international travel and globalization impacted?
Well, I don't think we're going to return to pre-pandemic travel anytime soon, just because people are going to be more nervous about traveling. And so they're going to be asking, do I really need to take this trip? In fact, in my academic circles, I hear people who go to a lot of meetings, travel a lot. They're now finding through Zoom and things like they're questioning whether they actually need to do that as much. So I think travel will be less for a while. And I think still people are just going to have to take extra care when they travel. Just again, like I said, thinking about distancing and thinking about cleanliness, that sort of thing, of your space in your airplane. I've seen people do this. I kind of thought they were a little crazy. They take out their wipes and they wipe everything down in the trays, and I've heard they're very dirty, so maybe there will be more of that. And let's see, what's the second part? I forget their second part.
Just, do you anticipate waves of infection?
Oh, yeah. In my mind, I kind of picture this like after the forest fire, where you still have things smoldering, and so you're just going to have to keep trying to control little fires from outbreaking again through testing, contact tracing, and just trying to control that way.
So Kim, I have a question concerning data, and in particular how epidemiologists clean and interpret data. So for people that aren't being tested, is that something that you are cleaning within your data sets, as well as maybe there's people that are dying from other ailments, like heart attacks or other illnesses, but that are also being included in COVID-19 deaths? Is that something that you are considering? Are those things that you are sifting through or cleaning when you are interpreting that data?
So I am not a COVID epidemiologist, so I work with this data for this presentation, but normally I work with cancer data. So I'm sure people are thinking about that who actually are working with this data, and how to handle other causes of death. It's a tricky one in general. If a cancer patient who is terminal dies in a car accident, how do you classify that person's cause of death. Is it cancer or is it a car accident? It's really kind of tricky. We call that competing risks. So I don't know what they're going to do, but I'm guessing there'll probably be analyses. Epidemiologists love to figure out how to handle those sorts of uncertainties through doing analyses both ways, excluding people who you know had underlying conditions, and looking at death rates from COVID, and then including them to get a total picture as well.
So Stephen is wondering about contact tracing and whether that's seemed to be effective or realistic in the current climate.
So as of right now, I can only speak from anecdotal information from talking to city and county here in St. Louis. It sounded like they were overwhelmed, and it's hard when you have so many cases. I think it will be more manageable if we have some electronic form of that helps us. I know Apple and Google were working on something to help us with that, which has other issues. So yeah, I don't think it's manageable when, as of right now, but it will become relevant again once we have things more under control and we start to resume normal activities.
How has social media played into epidemiology work? Has it hindered your ability to communicate truth or accurate information, or has it helped kind of proliferate important information as an epidemiologist that you want to disseminate to people?
Both. I think a lot of people are analyzing the data who haven't had a lot of experience or training, and I don't mean to there's a lot of smart people all over analyzing the data, but I think just having an appreciation as an epidemiologist of how data are collected and what the limitations are, as well as uncertainties in results, helps you to provide some nuance and context to your interpretation that not everybody has. So sometimes I think what is being reported on social media is not helpful by people who don't have that background. But I mean, I've seen a lot of other reports too that I think are very helpful. So I think it's a mix.
Cynthia is wondering about viral load in COVID-19. From what you're seeing, does that sort of initial exposure make a difference as far as what somebody's situation becomes, or do you know anything about that?
I think that's, I haven't seen any evidence, like any rigorous scientific evidence that viral load matters. I think right now is we're dealing with observations of healthcare workers maybe have an increased viral load, and so they're younger, and the first guy in China who was reported, he actually died of the disease, and so that was one of the theories around him, because I think he was relatively young, that he just had a lot of exposure. But so I think that will become known over time as we have time to develop and do rigorous studies around that question. But right now it's all pretty anecdotal.
So Darius has a question about how local community-based organizations can enhance their work through understanding epidata.
Well, it depends what the community organization does, but I think just understanding the surveillance data can help you understand like how common COVID is in your area, can help you understand, problems like, are we going to need more resources for healthcare worker childcare, or understanding different kind of data on food, what's happening with the food supply. Are we going to, and employment, and how is that going to affect people in our community, and what can we do to help address that, so that we don't have a lot of needy people. We can limit that to the extent possible. We're meeting their basic needs.
So we have time for just one last question. And Naren had asked something that I think is interesting. We're starting to hear about perhaps that COVID-19 was here in the US earlier than previously known. So there may be early cases that are not currently labeled and understood to be that. Do you anticipate that these earlier cases will we ever know?
So I want to say yes. This is really everybody, a lot of scientists from a lot of different disciplines are involved in these investigations. And I think this is my opinion that will be worked out genetically, because viruses mutate, and this one in particular, I think it mutates slowly through a process called drift. And so I've already seen the first studies that show that you can pinpoint the origin of where the virus came from through looking at the specific genetic mutations, so we can understand whether it came from Europe or China. So yeah, over time we're going to be able to understand those patterns of transmission, where the origin was.
Great. Well, Kim, I want to thank you so much. I know that you are not a COVID-19 epidemiologist.
Everybody is. No. all epidemiologists have dropped everything.
Well, I mean, it is a moment where we need your expertise more than we ever realized we did. And so I thank you for leaning in and giving us your best thoughts and some great information. I also want to thank a fantastic audience for really, really smart questions. We love hearing from you. And my handsome co-host, Lee Colliper, thank you so much. So this brings our session today to a close. I want to share just a couple of program notes with you all because this is an ongoing series, and we hope to continue to engage with you. So this Thursday, we're going to be joined by Brown School alum and adjunct faculty member Ian Forber-Pratt, and he will be speaking to reintegration and reunification of children to families in an international practice model. And we are continuing to add to this series. The response has been so strong. So just this week, we added 2 more dates, pushing farther. We're actually now adding programs into June. So if you haven't been on our free resources page in a while, I certainly invite you back to see what we have coming. And again, so grateful to Kim for her time, and to all of you for joining us. And we hope to see you again later this week on Open Classroom. Bye, everybody.
Bye.